And when it's done, it will take probably 30 minutes for it to transfer that recording onto your hard drive. It'll be converting. So you're going to have to leave it running, or you can terminate it and come back later and do it if you need to.
Okay.
But you'll have a local copy.
Yeah, I see the little thing that says pause and stop recording, so I guess it means it's recording.
Right. And you can, you know, you can pause it.
A little red button in the upper left. Good.
Correct.
And without driving you totally crazy, Elliot, I'd love to do this from 1 to 5 your time, also a Zoom for the summit.
The summit. Oh, well, we'll talk about that separately. Okay.
Right, and I'm not trying to drive you crazy, but this is a great platform for our summit. You know, for people like you and others to be in it as you're able.
Okay.
Okay.
We can look at that, and also, you know, we have to sort of scope out what has to be done, but we'll try.
Thank you, brother.
Where's your camera?
Right.
Oh, on there. Okay.
On Tom's Mac.
I'm gonna leave like this so you can see the audience.
So when I didn't have Kaiser computers, I got a Mac Pro. I had to pay for it.
I am being beaten down by Microsoft Windows 10 every week. The updates are just brutal. And I teach classes on Thursday nights, and that's when they tend to push out the updates. So I'm sitting there desperately trying to go through slides, and Microsoft is at one point actually shut my system down and rebooted it in the middle of a class.
Can't you go back to 8?
You know, you're right. 8 was not so stable.
It wasn't so stable, but I heard also about 10. I would never switch.
I would go back to 7, I guess. But it's mixed blessings. There's got to be a way for me to kind of intervene in when it pushes these out. I just haven't had time to sort that out.
But it's adding more and more kind of background, kind of consumption of memory. And
absolutely. They pushed Cortana back in because Cortana is going to be their Alexa.
Yeah.
Do you need this?
For me, XP was still the best.
You know that.
I don't know. I had a lot of blue screen of death on XP. I have 1/10 of the blue screens of death in Windows 10, although I do get the blue screen of death. The Windows 10 has, as a blue screen of death, it has a sad face with a frown. And I'm sitting there, and my daughter says, "Dad, what's that on your computer?" I'd never seen it before.
So Tom tells me you're doing a lot of teaching.
Yeah, there's a lot of work in the health IT and information system security, privacy. It's very busy.
Great. Well, I guess it's good, right?
Absolutely, and in fact, except there's only one of me, and there's only so much I can do.
Right. Yeah.
I'm trying to give this stuff away. So Ricardo is co-teaching with me. Ricardo Silva is co-teaching one of my classes, and to the extent possible, try to get Tom set up and others to do some of these courses because literally there's only one of me, and I don't want to be doing this 24 hours a day.
Right. Well, I retire in 3 years' time, so I'll be looking for something to do.
We will certainly not have solved most of these problems by then. So
we'll got the African branch.
I just got a funny. I see we're still waiting for folks to gather. I just got a request. The University of South Florida is starting a medical engineering curriculum, and they want a dean. And suddenly I get a faculty search, and I'm like, wait, I'm trying to retire. I'm trying to sort of slow this down.
Elliot, good luck with that.
Yeah, right.
Cometh the hour, cometh the man.
Let's slowly get started here. I know more will come in, but to be fair to Elliot's wonderful presentation and just 500 slides. So Elliot, I'm going to let you introduce yourself because
All right.
part of your deal. And welcome to this workshop, and welcome to a world-class presenter. And it's not me. So we're all delighted. Take it away, Elliot.
Thank you, Tom, and thank you, friends, for joining me this morning and giving me the opportunity to share sort of the intersection of my professional work that is probably very similar to either what you are working on or what you are experiencing in your countries or programs. You know, I'm calling this an advanced clinical engineering workshop. We don't have really good names to describe this. We're wrestling with terms like health technology management and CEIT, clinical engineering IT convergence, and CE or HTM and ICT, depending on the audience. International audiences, European audiences are more comfortable with ICT, information and communication technologies. All of it is the 21st century of converged technologies. And from my point of view as a clinical engineer, these are all our turf, regardless of what you call them. When there's a patient connected to technology, when the life and death and outcome and care depends on the technologies working, we own that turf, and it's a very challenging and interesting area professionally to be working in the information technology side, because that is a rapidly evolving field too. So I'm going to go through a number of slides, background slides, just my own background, about 4+ decades in this field, 15 years with ECRI Institute. I was first in Brazil, I think, roughly 1985, working with Ben-Seng Wang and one of the early clinical engineering conferences in Rio, and also visited Campinas and the new hospital and the clinical engineering program there. Spent 15 years at ECRI, and about 3 years in to being a clinical engineer and testing medical devices, I was asked to start building the information technology infrastructure, and that activity really has continued. The crossroads between those two fields has continued for the rest of my career. About 10 years after leaving ECRI, I worked for 10 years at Medic in medical device manufacturing. Again, the pleasure and privilege of working with Ben-Seng Wang, where we managed nearly 500,000 medical devices. And I don't know, somehow he and I lost a good part of our hair and the color in our hair, trying to make sure that medical devices didn't hurt or kill anyone as we used them in 101 cities around the United States. Thank goodness it was a full-time exercise for him and me and 2 other clinical engineers and a large number of biomedical technicians. And then since that time, I've worked as a professor, consultant, and businessman. I've run a small nonprofit research organization. It's a newly named and created one, the Foundation for Living Wellness and Health. And at another time, we'll talk more about that. I am also a professor actively teaching at Villanova University in Philadelphia. Even though I'm located in Florida, I'm online every week with Villanova University's graduate programs in computer sciences and nursing, and also with South University in their business school. I recently published a chapter on management of complex clinical systems with Ernesto Yadanza and his community, because it's been gnawing at me that we really have to start looking at the very complex interconnected systems, and some of what we're going to talk about today delves into that a bit. And there are some pretty good examples in the other chapters as well that talk about converged clinical and information systems. And we are getting to the point really where you can't tell the beginning or end of the information technologies and the clinical technologies. They're all interwoven quite tightly. And as we move to software as a medical device, around the world, apps software applications. We're going to bring all of the challenges, advantages, and miseries of software and firmware to the medical and clinical field. I know many of you in the room fairly well as friends and colleagues for many years, and so this is sort of repetitious, looking at the real cost of ownership and also life cycle cost and total cost of ownership. The total cost of ownership model really comes out of the information systems field, and that has, we'll be talking quite a bit about that, but as information systems evolved from mainframes to personal computers, there was, in the 80s, a perception of, well, computers are cheap. You pay a couple $1,000s and you have a computer. You can replace $1 million computer. But what actually has emerged is the cost of ownership of large numbers, hundreds and thousands of personal computers and now smartphones, is quite high. And the maintenance and management of reliable systems built at that scale is quite difficult. So here are some headlines from just this past month, mostly. There are a few others. This is just this past week. I noted, sadly, that Dominica's main hospital was badly damaged when we were there with the Pan American Health Organization in 2001. They were very proud, very well equipped, and were doing a fine job. And now they are really back to square one. In fact, the picture in here in the center, the main street is filled with shards of wood. It looks like a lumber yard. The streets are impassable, and there are no power or communication systems left standing in Dominica. Houston, where Yadin is based, at least one of the hospitals had to be evacuated, and apparently they had trouble evacuating the hospital, so the patients were running low on food. And I think Yadin probably, if he leans out of his apartment window, may be able to see Ben Taub Hospital quite clearly. And I think the water was just about at his front doorstep as this next one, Hurricane Irma, which is in my backyard, forced at least 35 hospitals in Florida. Irma was recorded as one of the strongest storms in history. And there are hospitals in New Orleans after Katrina that never even reopened. The damage was so substantial. So as we look at total cost of ownership, we really have to consider the impact of interconnected systems that are interdependent. We get great power and leverage with the ability to do advanced diagnostics, tumor analysis, very complex pathologic studies and systems, population health data and analytics. But all of these systems all have to be kept working and reliable, or they take each other down potentially. And there are costs. There are a lot of costs in managing such complex systems that we didn't have when a single infusion pump's battery failed or a single patient monitor's telemetry system failed. We're now talking about systems that can affect entire communities as we also push out healthcare into home care. Even when Binseng and I were at Medic in the 90s, already a third of healthcare was happening outside of the hospital. And in the US now, 2/3 of healthcare happens outside of the hospital. So ventilators, infusion devices, defibrillators, many technologies that we believed and experienced as hospital only are elsewhere. Hurricane Sandy. I moved from the Philadelphia area the year after Sandy to Florida. I guess I wanted to see a bigger hurricane than Sandy, so I moved to Florida so I could see Irma. All of these natural disasters they're sort of indicators of the challenges that we face in healthcare, and we'll talk more about that along the way. Mexico just had a major earthquake. There's a general hospital that's collapsed, and in Haiti during their earthquake, a hospital collapsed. So again, total cost of ownership, when you think about the support of infrastructure, you really do have to think hard about what does it cost to keep a system running completely. I had the privilege and opportunity to review the design plans for, I think I can name it, Cleveland Clinic's Abu Dhabi facility. And one of the things that I pointed out to them, which I think they rectified, was they only had a single a broadband internet access into the hospital. So if that internet access failed, they would have no other way of communicating out or into that hospital. Redundancy and the costs of redundancy are all part of this total cost of ownership. Power systems, redundant power, all part of the reality. So this is the actual track of Hurricane Irma just 2 weeks ago, 2 Saturdays ago. My home is right here on this this little edge of Sarasota. The actual track of Irma is here. The hurricane force winds are this. So about half of the neighborhoods around me still don't have power, and there are anyone who doesn't have power also doesn't have sewage or sanitation. So they're told not to flush the toilets because there's no power to move the sewage in through the systems and treatment. We actually drove 16 hours to Biloxi, Mississippi. We left on Friday, and we were about the third wave. Most of the folks had left already Miami and the East Coast. So we and everyone from Florida was returning. 16 hours of interesting driving, and about 4,000 power trucks coming in from, we saw New York, we saw Texas, we saw Indiana, Michigan, power trucks coming in. There are still about 250,000 people without power in Florida, and that's nothing compared to Mexico's power problems right now, or think of Dominica. Thoughts of introspection as I think about total cost of ownership. Smart hospital and medical home, they all rely on interdependent clinical and information technologies, and they're all vulnerable to natural and man-made disasters. What's a man-made disaster? We're having more and more attacks in the U.S. and internationally with cyber attacks on hospitals and hospital information systems and on medical devices. St. Jude Abbott just recalled 500,000 implanted defibrillators in the U.S. and pacemakers, and another, I think, 300,000 internationally. That's almost 1 million devices that have been recalled by the FDA because of vulnerability to hacker attacks. So we're facing man-made disasters that are quite significant. The Internet of Things attacks last October, November, and the beginning of this year in Germany. Deutsche Telekom lost communications internet services for almost 1 million German customers through the Internet of Things attacks that went on at the beginning of this year. Cell phone coverage, mHealth, mobile technologies, wearable technologies. We have more and more devices that are such as diabetes management systems that are interconnected with cloud and app systems. Those rely on broadband and cell coverage. We still have areas near me where people aren't able to get cell phone coverage after the hurricane. And of course, Dominica, Mexico, there are areas that will probably be months before they have access. Naples and the Florida Keys as well. Interestingly, in the U.S., I can't speak internationally, the telecom companies are eliminating their wired telephone services in favor of wireless telephone services. Verizon in the U.S., one of the largest old Bell telephone companies, sold all of its communication business in Florida, Texas, and California so that it could get out of the wire connection, the twisted pair, the good old-fashioned telephone, and focus only on wireless, because there are not laws requiring broadband end-to-end last-mile communication with all customers. And so this build-out that has happened throughout the world, China, the former Soviet countries, Latin America, Africa, this build-out with cellular networks is another area of vulnerability and really significant cost, hidden cost in the sustainable health infrastructure. So that we've all used, or many of us have used this iceberg for a good long time. The tip of the iceberg, the visible part of purchasing technologies, is only a small part, and of the ownership costs, we've used estimates like 20% of the cost is in the purchase cost, and 80% is below the surface. It's the repairs, the updates. As we move into total cost of ownership with information technologies, I think we're looking at the cost of purchase being only 10% and the long-term support costs being more like 90% or more. And that's the learning curve for the IT industry. The chief information officers in hospitals and healthcare has been extremely steep. When you have 5 PCs in your accounting department, it seems like not such a big deal to have to upgrade a hard disk drive. When you have 1,000 or 2,000 PCs in your hospital, and they're all laptops, and you have to replace 2,000 batteries or replace 2,000 laptops, you're now talking about some significant consequences. Ben Sang is there with you. He can tell you some of the challenges we faced at Medic. We had 40 or 50,000 infusion pumps, and we had to replace the batteries in those infusion pumps every 2 years. So that was as many as 40,000 batteries in a given year. You don't just put those in the trash can. Those are truckloads and truckloads of toxic waste that have to be dealt with. We had to pay to have those batteries taken. It's all part of the total cost of ownership that is hidden. When I first started at Medic, we had just moved into battery-powered devices, and we delivered devices to our colleague Joe Dyro, who many of you know. We delivered about 25 infusion pumps, and 2/3 of them had dead batteries. Why? We hadn't put power and charging stations in the branch offices, and so the batteries weren't being maintained. These are examples of costs and requirements that have to be calculated into this expanding world. All of us have, I'm sure, smartphones, Android or iPhones, and dealing with the fact that as iOS goes to iOS 11, they will orphan a whole generation of smartphones that will not be able to be updated with current software, antivirus, and other tools. Those all have hidden costs and total cost of ownership. So, let's look at where we're headed in the digital hospital of the 21st century, and I'm going to be giving some examples, and these are examples I've seen in Kaiser Permanente. They're examples I've seen in the PLA hospital in Beijing. There are technologies that I've seen in hospitals in Europe. So they are not futuristic, they're really being implemented. New hospitals, new buildings are being developed as IP, Internet Protocol addressable systems. They're based on essentially the Internet of Things. Everything is addressable. Now that in and of itself has a hidden cost and a cybersecurity challenge that is quite significant. The fact that you can go into a store or order online a light bulb that can screw into a regular light bulb socket and be an IP addressable microphone, speaker, and camera now has potentially profound privacy challenges. But beyond that, that device can also be used as an attack bot to take out portions or all of the hospital's communications systems. So how do you know that those are being put in? How do you manage or monitor those? How do you factor those costs into the cost of ownership? Those Internet of Things technologies were the technologies that were used in the October and November's attacks in the US that created the largest denial of service attacks ever recorded. Isn't it exciting? We have the largest hurricanes ever recorded, the largest cybersecurity attacks ever recorded, and it obviously the two aren't related, other than the fact is that we are depending on, and these systems are interdependent, and if you lose communication, storage, access, stability, reliability, you add significant potential patient risk in the mix. 21st century hospitals, IP, Internet of Things, wired and wireless optical networks. There's now a new generation of optical wireless communication. So you can take that light bulb, screw it into the outlet in the ceiling. It can become a Wi-Fi. Well, they call it a Li-Fi. It can be now a light-based communication system within that room or within the hallway or within the building. That's good and bad. The nice part about it, a lot harder to block with a radio transmitter. On the other hand, a lot harder to discern that it has been put in the system if you haven't given permission to do that. Comprehensive patient and staff-centric electronic medical records. We have around the world now more and more adoption of electronic medical record systems that are being optimized to workflow, and they're replacing paper. That's the good and the bad news. Any hospital you talk with that has used these systems can tell you the day the systems failed and they had to go back to paper. And how do we support, what are the costs, the underlying costs to maintain a system that is either so reliable we don't run that risk, or that maintains backup paper or computer or record systems to allow us to continue delivering patient care? An example of the risk is Hollywood Hospital in Los Angeles that was taken out for 2 weeks by a ransomware attack. There's another hospital in New York City that was taken out for 6 weeks by a ransomware attack. That's the ransomware happens to be the attack method or vector, but the reality is other things could have caused that failure and caused the hospital to be unable to deliver patient care. And it's as serious a problem as a hurricane or earthquake. Smart buildings, letting the building do much of the background work. So the buildings already do security, they do temperature, environment. I have talked in other presentations about the sentient hospital, a hospital that is actually aware of the people, the patients, the visitors. Why not? When you think about it, it looks like Star Trek. It looks like the enterprise that knows where the visitors are, where the staff is and team is. But those sensors all are exposure points for interference or failure. And we're now building out at a metropolitan area network level. This isn't just a hospital. We're building out systems. Ford, Tesla, General Motors, Volvo are talking about putting physiologic monitoring systems in the cars. And you think, well, why not? I mean, they're monitoring traffic, they're monitoring other life-critical information. Why not also monitor the person or persons in the car? But you know, how do we manage that? All of us come from a heritage of trying to provide a 100% reliable clinical monitoring and management environment. It's pretty hard to do when you move out into the built infrastructure outside of the hospital or in the patient's home. Binseng is there and can share with you some of our challenges of medical devices that were designed for hospital use taken into patients' homes, where the power, humidity, dust simply disabled the equipment, creating very, very serious risks for the patients and very serious challenges for the family and caregivers. Also, automated logistics. We're leaning out the supply chain around the world. And that has great financial opportunities, advantages, but also some really big risks. For example, the U.S. does not manufacture antibiotics anymore. All antibiotics in the U.S., to my knowledge, are manufactured either in China or in Eastern Europe. So our supply chain is now based on a shared supply chain around the world. Ranbaxy makes erythromycin. If we don't have erythromycin in the U.S. when we need it, when we have an epidemic of a disease, of a flu, of a pneumonia, if the world experiences a pandemic, the stockpiles are not necessarily available to support that care. And then the whole issue of eco-friendly infrastructure, Most countries, apparently the U.S. has excused itself from the Green Revolution, but most countries, and in fact in the U.S. most states and cities, are still quite concerned about the carbon footprint. All of these are part of the 21st century digital hospital characteristics. I'm not going to dwell too much on the IP, Internet of Things, interconnection. It has tremendous advantages, but it also brings with it tremendous generic risks. We do not have protection. We do not have cybersecurity or reliability methodologies developed that are robust enough. You don't have to look any further than the last 2 weeks. Again, we had these tremendous storms. We also had our largest credit firm in the U.S., Experian, lost control of half the U.S. population, Social Security numbers, and personal data. About 150 million Americans' data has been exposed. Social Security numbers, date of birth, addresses, financial information has all been exposed. And one of the most common attack points using that data today is getting people's medical information. It's a whole separate story about why that has become so popular as an attack point, but it is. And then the concept of the staff-centric EMR, we're leaning out staff. We're trying to optimize how many patients a nurse, a physician, a phlebotomist can see in a given hour or given day or a given week. But that depends on the system all working reliably. We are mentally conceiving it of like a Amazon.com, working 24 hours a day, efficiently scheduling people and resources and facilities. But the reality, the real world, doesn't hand out problems in that even flow. Hurricanes happen. We have cyber attacks happen. We have flus and pandemics that happen. So we don't have the same kind of manufacturing environment that you would have. This is much more like warfighting in many cases than manufacturing. There is general agreement that electronic medical records improve patient care, at least at some levels. There is a lot of research and concern about how much money and how much energy and attention gets refocused away from the patient, away from patient care, how much data is hidden in the process of moving to electronic medical records, how many shortcuts and workarounds people do. One of the examples is barcoding of medications, which is shown in the image on the right-hand side. Being able to barcode scan a medication and the patient is arguably an excellent methodology, and that is a methodology used in most grocery stores and airline ticket counters around the world. However, when you study what nurses actually do, it turns out that a large number of nurses in many clinical situations work around the system. They don't want to wake the patient up, so they keep a list of all the patient's barcodes inside the door or drawer or on a board. Or they don't always get the medications in the right doses from the pharmacy, so they keep a bunch of tags that they can scan to get the right dosage to match up with the patient. It's kind of like what happens with people with cars. If the speed limit is 60 miles an hour, people drive at 70. You wind up with nurses and physicians using the systems, we call it in healthcare riding the guardrails, and then they wind up essentially falsifying records in order to either meet protocols or provide to paper the record to meet protocols. So the electronic systems are subject to the same kind of abuses that paper systems are, in short. Robotics are making more and more contributions in healthcare. We have food delivery, pharmaceuticals, med-surg supply deliveries, automated. I I've seen this in Ford factories. I've seen this in hospitals. Those are all dependent on the communications, the RFID, the scanning systems. They have tremendous benefits in optimization and improvement, but they're also a lot of hidden costs. When the systems don't work, there has to be a way, for example, to fall back and deal with manual dispensing of pills. When Yadin and I were in the People's Liberation Army Hospital on a tour, I think about 2 years ago, we saw their automated pharmacy and packaging system. It was a marvel. They had a liquid unit dose packaging system and a pill unit dose packaging system. State of the art. Every package, every bottle had a patient's name, had a barcode. It had a serial number, lot number. It was a beautiful, remarkable system. But the cost of building and supporting and maintaining those systems, the support of computerized physician order entry, supplying the unit dose cartridges so the pills or the liquids can be dispensed and mixed in those systems is not insignificant. All part of this real hidden total cost of ownership. RFID, putting RFID tags on more and more things, including surgical med-surg supplies, so that we can count sponges before and after surgery to make sure we didn't leave some in the patient, clamps and medical instruments of various sorts. Memorial Sloan Kettering Hospital has an example, very lovely example, of how they have created a kind of a cone, an antenna cone around the patient where they can use the smart tags to inventory and track devices, supplies, medications with hands-off automation. Beautiful, interesting examples. But the cost of doing that, the cost of building the infrastructure, maintaining the infrastructure, and we'll talk a little bit about verifying, validating, and making sure the infrastructure is working properly as you do changes through time, that's not so trivial. So we have all of these ICT moving into all of these Internet of Things areas, and so we in the clinical engineering, health technology management field are inheriting all of the challenges that have come and been learned, largely overcome, but not completely, in the IT field. I find it fascinating how many of my clinical engineering colleagues in the US still continue to say that they really don't do IT. They don't see IT as part of their responsibility. They don't see IP browsers, apps as being their area of knowledge or concern. I guess they could turn their back on that, but the consequence of doing that is you're leaving programmers in charge of patient safety and in charge of clinical operations, which to me makes no sense. And we have to sort of figure out how to interconnect those very, very effectively. Talking about digital hospitals, we can also talk about how do you categorize digital hospitals and the digitization, the sophistication of hospitals. There is a maturity model that HIMSS, the Health Information and Management Systems Society, has developed for the past dozen years. They wanted to kind of figure out, how sophisticated are hospitals and how much penetration is there of technology. They have stages 0 through 7. Actually, I've talked with them for the past 4 or 5 years. I think they have to add stages 8, 9, and 10 to really get to the reality of patient care outside of the hospital, mHealth, mobile health care, mobile technology, self-care, patient portals, and patient engagement. Around the world, we're seeing almost every country that I talk with, the concept of home care, self-care is being emphasized and implemented. Again, when Bin Seng and I were working at Medic in the 90s, we were told by almost every country that we worked with that they don't do home care. They don't believe in home care. Patients come to the doctor, they come to the physician, and that's the only rational way to provide care. Today, everywhere that I go talks about home care as one of the fundamental solutions to the challenges of aging societies, high cost of care in hospitals, nosocomial infections, quality management issues, and also giving patients control and empowering them to make their own decisions in care. So this is what the ladder of capability looks like at HIMSS. Down at level 0, there's no electronic information systems. In level 1 has some ancillary systems like radiology and pharmacy. And as you move up, 5, you get closed loop medication administration. The research that's been done in the To Err is Human series in the US and internationally has documented that medication errors are still a massive source of patient injury and cost and waste. So the barcoding, 5 rights, right patient, right location, right dose, right drug, right time, is a significant a breakthrough area. Physician documentation with structured systems and decision support templates, full PACS picture archiving systems, and also at the top level, sharing clinical records with other caregivers, data mining, analytics, clinical decision support. Tom Judd is there, can tell you personally about a lot of the work he's done with Kaiser Permanente in working with this and also reviewing other hospitals for awards on behalf of HIMSS. There's a tremendous amount of progress that has been made in the US. In 2005, we had only maybe the bulk of the hospitals were at level 3 or below. In 2017, the bulk of the hospitals are now up here at level 6 and 7. Physicians are probably more in this 4 and 5, but physician practices moving up as well. And all of this is integrating and creating interdependencies and costs, significant clinical costs that we have to be aware of as we go through this transition. The HIMSS analytic methodology is a cumulative one. You can't jump from stage 1 to stage 4. You have to kind of go through each stage of maturity. It's like other communication or computer maturity models or technology maturity models. And it's assumed that the ICT infrastructure is reliable and robust, which in fact it is not. We are overdriving. We have overdriven most of the ICT infrastructure in hospitals many times over. As recently as 5 years ago at a Radiology Society conference, I was working with a large medical device monitoring manufacturer and having a bit of an argument with their chief engineer, who insisted that that there was plenty of bandwidth for their monitoring and alarms. And as one of the large PACS vendors went by, I said, come here, tell me about your use of the wireless systems. And he said quite glibly, oh, we send 80 and 90 gigabyte files through the wireless network for radiologists and physicians all the time. And the chief engineer at the monitoring company just blanched. He said, well, you shouldn't do that. Well, that's like saying someone shouldn't drive their car on the highway because you want to use the highway for your own application. We have some real serious challenges in infrastructure build out and support. So we have issues related to integration, interoperability. We have cost issues, layers and layers and layers of cost issues buried under there. We have from stage 3 up, ICT system security becomes a significant issue. As your systems become more dependent, more interdependent, as life-critical functions, as diagnostic decisions now become based on the system, you now have to make a significant investment in security. You can use many different models. The U.S. HIPAA model, Health Information Portability and Accountability Act, really leverages a fairly old historic information technology framework, CIA, confidentiality, integrity, and availability. Confidentiality is what we kind of obsess about around the world, which is my data is mine. I don't want anybody to see what diseases I have, what illnesses I have. I don't want anybody to take my insurance away. I don't want the government to intervene in my access to care. But integrity and availability are the areas that are where our headaches, heartaches, and stomach aches really have to come in the health technology management. Integrity, making sure the data actually is not damaged and is retained correctly and matched with the right patients, and availability of systems is a massive, massive challenge and issue that we have not addressed well in any aspect of the information technology field. So we have vulnerabilities. We have in the US, NIST has a National Cybersecurity Center of Excellence that is looking at issues in our smart grid, in our water management, and also in healthcare and health systems, health devices, security and reliability. So we have essentials in the digital hospital era in this 21st century. Really, all of these systems have to be designed and specified in advance. No department wants to be told that. No manager wants to be told that. The IT folks don't want to be told that. But the reality is there has to be planning and architecture. You can't just accidentally build a reliable system. There are no systems that have been built that way. They require software and systems engineering. There are a number of groups and organizations looking at that. Most of the financial, business, and health management models expect that these interconnected, interdependent systems will be functioning and available. And then the internal infrastructure, wireless and wired networks, security systems, firewalls, servers, cloud-based resources, all of those have to be spec'd out and developed, and we're way ahead. We have outpaced, and we have been outpacing our knowledge in the healthcare field. We have been applying technologies. I have written and testified that I believe it is essentially human experimentation. Nobody likes to hear that. The government likes to say that that doesn't happen. But the reality is, in my mind, if you send a patient home with an app that has not been validated to help them manage their diabetes or asthma, that's human experimentation. You can call it other things, but if you just tell the patient, choose one of those and you can take care of your illness or disease or rehabilitation, that's not really an appropriate way. That's not the way we have designed these systems to work. We also have interoperability, the connectedness of things. We take email and instant messenger as fairly essential and trustworthy capabilities, but interdependent, interconnected systems can't be taken for granted. Last time I was in China, I was blindsided by the Great Wall of Gmail and Google. None of my Google resources, my email, my maps, my contacts were available. So the reality of interdependence and interoperability, it has to be engineered into systems. Until the last year, I've been the co-chair for almost 15 years of integrating the healthcare enterprise, IHE, working on developing common interconnection modalities and methods. They're open source, they're available for all vendors and hospitals, and slowly but surely they are being implemented and used, but they bring with them the challenges that come with email, things like spam, the challenges that come with email, worms, viruses, and attack vectors. So we gain in one hand and we lose in another. All of those affect the total cost of ownership of implementing these technologies. In general, as we build these smart systems, we want to come up with specifications that are relatively generic and open so that any manufacturer can plug their system into the common infrastructure. PACS is perhaps one of the best examples of a fairly highly standardized environment where DICOM, JPEG, and other images can be shared across many modalities, ultrasound, pathology, radiology, mammography, reliably and securely because of all the work that's been done to standardize those interfaces. Total cost of ownership considerations in digital hospital construction. Even back when I was at ECRI, which is a long time ago already, hospitals were building new wings without network considerations taken. ECRI was called in to actually hammer network technologies into the hospital after the whole infrastructure was built. Most departments do not have an inventory of what their bandwidth requirements are. Most hospitals do not have an inventory in planning of what their bandwidth and requirements are. Most physicians that I have met and many IT people that I've met believe at some level it's a magical thinking that the capacity is almost infinite. And not only is the capacity not infinite, the capacity is not adequate to meet the 1 or 2 minute time constraints of life-critical alerts and alarms. So we need very, very smart planning, design, and architecture, and that has a lot of cost. A lot of cost in the initial phases, and also a lot of cost in the renovation phases. So every stage of the life cycle of equipment presents contributions to this, whether it's 80% of the total cost of ownership or 90% of the total cost of ownership. We have a role and responsibility in managing these long-term costs, not just managing, but predicting, evaluating, assessing, using that information on those longer-term costs in our decision-making. Many of you have done a lot of work in health technology assessment. These are very similar to health technology assessment methodologies. You could call them a micro-assessment, so you're trying to look at an assessment for your individual department or hospital or regional state health system, as opposed to trying to look at a macro health technology assessment about a chemotherapy versus a surgical intervention. These are assessments that have to be done with a fair amount of care and attention to detail. I have worked with some very, very bright, well-qualified senior clinical engineers and have been shocked at their naivete about assumptions about what could or could not be provided in the way of storage, backups, communication capabilities, reliability, disaster planning, contingency planning. There are any number of pitfalls, a large number of pitfalls, that come from our clinical engineering and health technology management side when we don't have much information technology management experience to draw from. So we have to look at managing and understanding long-term costs, managing economic risks, and evaluating better alternatives, very much like general health technology assessment. Certainly, we can't get around the fact that the world is expecting to move to wireless. It's already moved to wireless. Physicians are and nurses are on wireless tethers. Patients are on wireless tethers. More and more patients are receiving their medical guidance and feedback through smartphones, apps, and that's going to continue. We will have, I believe, in the next 3 to 5 years, we will see adaptive medical devices, closed-loop medical devices. We're working with the Food and Drug Administration on the methodologies to validate and approve such systems. There's a lot of trepidation, but seriously, if we're going to have self-driving cars, we're going to have self-adjusting infusion pumps. The game is changing very quickly, and wireless is our safety net. Wireless is our backbone for most of these systems. But the wireless systems, in testimony I had with our Federal Communications Commission and our Food and Drug Administration, the wireless providers were very upfront, and the manufacturers of the wireless equipment, saying, we don't manufacture equipment to life-critical specs. We have no ability to develop, design, or deliver such equipment. I have met with IEEE standards groups with the 802.11 whatever, Zigbee, Bluetooth, Wi-Fi, WiMAX, and to a person they have said, we don't design this stuff for a life-critical application. You folks ought to develop your own. But we can't in healthcare really afford to develop only health-based wireless networks. And the bandwidth that's allocated to health is not set aside just for health applications. So really, there's an entire area of wireless network engineering and analysis that is going to be required for proper management, design and management of hospitals and health settings. And in all of the planning, there has to be a piece of the planning on contingency planning. Those earthquakes, those hurricanes, those cyber attacks, all take capacity away. And how does one deal with supporting patients in nursing homes, independent living centers, when they are connected by a wireless link, when your physicians and nurses are connected by wireless links that are offline or are essentially disabled? During Hurricane Irma and for the week afterwards, as an example, my phone almost never rang. I would get periodically, my cell phone almost never rang. I would periodically get a notice of a message that had been left. Someone called, they never got through to me, they left voicemails, and then the notification system could only get a finite number of notifications out for voicemail. So I would get an hour later a notification that someone had left a voicemail. I would send a text message or 2 or 3 text messages, and the text messages would stall, and the messages didn't get to me. In fact, the way the iPhone text messaging system works, I don't know about Android, if the text message fails, at least with the AT&T network, I have to resend it. It doesn't automatically keep resending and retrying. I have to go back. I have to look to see that it was not successfully sent and resend that message. Well, what if that is a message about increasing or decreasing the Coumadin dose for a home care patient? It's a critical piece of information, or increase or decreasing insulin for a patient or other medication, life-critical medications. We are building infrastructures that are really at risk, and there are costs to make them more robust. Here in Orlando, we have Nemours Children's Hospital. Nemours Children's Hospital originally was in the Philadelphia, suburban Philadelphia, it's actually Wilmington, Delaware area. When they moved their hospital and built their hospital, beautiful state-of-the-art hospital here in Orlando, they decided to move their IT support down to Orlando and their home patient support down to Orlando and their intensive care support. So all of the patient care in Wilmington and Philadelphia and all of the patient care in Florida comes out of their clinical and telemetry and informatics unit in Orlando. Well, they were very lucky they weren't flattened by Irma, because they would have lost the ability to provide support and communication for their patients in Philadelphia as well as Florida. We have to start thinking about the hospital as a patient. The hospital's communication system is its nervous system. We really have to start looking at the costs and including those costs in our projections as we build these smarter and smarter and smarter systems. It is just like concrete and steel. It's just like the HVAC. And you can, hope that the hospitals or the departments are not going to choose these closed-loop medical devices, but in fact they will, because they will reduce the workload, they will increase the capacity for patient care, but they will all depend on reliable infrastructure to provide safe care. And by the way, the Food and Drug Administration's position on this is they are not going to constrain these innovations. The Food and Drug Administration in the U.S. has said it is the responsibility of the manufacturer to anticipate and design solutions to likely problems, and for the purchaser, the hospital, to manage the risk. And all of those costs are borne in large part by the hospital. We also have these commissioning issues. When you bring together a system with 200 or 300, a hospital, 200 or 300 different information systems that all have to work reliably, pharmacy, laboratory, pathology, radiology, intensive care, patient monitoring, infusion care, logistics, supply chain, all of those have to work reliably. Those hospitals now have become complex factories. They're systems of systems. And there are actually very few experts in the field who can go through a hospital and work with and document all of those systems and do the necessary planning and information for those systems. Okay, thanks, Tom. So we don't just have the planning costs. We also have the implementation, the rollout, and we also have to plan for future capacity. And how is that future capacity going to be implemented or provided if we haven't fixtured the hospital, designed the hospital to allow the growth that is likely over the next 2 to 3 to 4 years in healthcare settings? Verification and validation is kind of where we hit the maintenance challenge for complex systems. Systems of systems are not easy to validate. If you take a blood pressure monitor, you can calibrate its millimeters of mercury. If you take an ECG monitor, you can calibrate its frequency response, its sensitivity. You can calibrate the pulse oximeter to your own finger or to a phantom. You can calibrate an ultrasound system to a phantom, or a radiology system to a phantom. But systems of systems are very, very difficult to validate. If you have a multi-modality imaging system that is feeding a clinical decision support and analytics system, you have to validate each individual component in that system and the combined systems and the infrastructure behind the walls that you can't see. Take, for example, smart alarm systems. We have a company here in Sarasota, Volt, V-O-A-L-T-E, bright young engineering firm that takes the alarms from a large number of different vendors, monitors and modalities, runs them through a central processing and alarm management system, and then fires off communications to nurses, physicians, allied health professionals to alert them to increasing risk and problems at the patient's bedside. How do you validate that system? How do you validate that once you've installed it and it works per specification, and brand X manufacturer has added some new enhancements to its algorithms that change its responses and communications of alarms to this Volt system, this intermediary system? How do you validate that the nurses and physicians are getting the correct messages? You have two different pieces of this. You've got the individual, we have several, you have the individual device and monitor, you have the firmware in the monitor, you have the firmware in the central station, you have the communication link to the Volt alarm integration system, you have the communication from the Volt to the apps on the Android and iPhones, and all of these things may be getting updates. I don't know about your smartphones, but my smartphone every week has 20, 30, 40 updates that it wants to put into my package. And Microsoft every week now is giving me updates that is taking my system offline. How do you validate and how do you cost out the validation process needed? So you have verification and validation. You've got two different kinds of concepts here in the IT field, and also it's true in the medical device field. Verification is making sure the system operates the way it's supposed to, and validation that it's doing the right thing clinically. So each piece in the system may be working fine. The patient monitor may be working fine, the central station may be working fine, the communication system may be working fine, the Vault alarm integration system may be working fine, the apps may be working fine, but all of the pieces together may not be working correctly. We don't have time to test all of the systems, all of the functions, all of the functionality. We're going to have to develop new methods for triaging and identifying the critical paths and the critical changes and the critical verification and validation that has to happen in order to make sure our systems are working reliable from day to day, week to week, month to month, year to year. Our world is changing quickly, and we can no longer just put a sticker on a monitor and say, we're good till next year. Not if that monitor is actually going to affect a decision support system that is going to make a drug and medication recommendation and a discharge recommendation for that patient that's actually incorrect. So doing the right thing, does it work right, and also is it doing the right thing in the situation, are the challenges that we have to address. Those are huge costs. Those are huge costs in engineering skills and training and knowledge. We have to develop an entire new library of CMMS, computerized maintenance management systems, that support this kind of complex system. Because we have to be able to identify the interdependencies of each of the individual subcomponents in order to even begin to map the actual life-critical, mission-critical, operations-critical functions and features. So you have this area of installation, testing, commissioning, where what we used to do was unit testing. Ben sang, you know, he can share with you our war stories of getting a truckload of ventilators, 500, 600, 800, a truckload of apnea monitors, a truckload of bilirubin. We would buy things by the truckload, almost by the train car for medic. There's nothing more disheartening than to receive 400 of something and find out all 400 were assembled incorrectly. That's unit testing. But when those actually have to now interconnect into hospital-specific systems, we're now upping the ante and complexity quite substantially, and the costs. So this is part of our evolving responsibility, perhaps opportunity, depending on how you look at it in this field. So the point here is that there's really no free lunch. We are getting enormous leverage and improvements in clinical care. We're getting tremendous improvements in efficiency, throughput, dramatic new diagnostic capabilities, the ability for patients to self-manage, feed themselves, have better quality of life. All of those are very, very good, but we also have to start dealing with the cost consequences and planning those much more effectively, and also building our management, our health technology management skills at a much more sophisticated level. Life cycle cost analysis comes into this as a financial methodology that was first documented by ECRI in 1988 in their health devices issues, devices and dollars. And that's the first time that I read articles that really made it clear to me that you can't just take the dollars and add them all up into a big column of costs and pretend the job is done. There are actually year by year by year by year costs that can be planned, that have to be analyzed based on the time value of money. And as I traveled internationally with Pan American Health Organization, with colleagues like Binseng and Yadin and others, we also began to learn about the currency and devaluation and the complex interest rate gyrations that go on around the world. I had no idea for example, until last year, that in Italy, the interest rates for loans is kind of integrated. Yes, it's all in the euro, but the interest rates are used to adjust the actual risk for the Italian economy versus the German economy versus the French economy. So they actually have to have different numbers. It isn't as if they all have euros and the costs are all the same. The costs are not all the same. There's an impact across each country that is different. And now as they deal with Brexit, as they deal with the changing global dynamics, we have to factor all of those issues in as well. Tom, why don't we take a 5-minute break now and give people a chance for a quick bio break if there's coffee available, and then we'll come back and continue the discussion.
Very good, Elliot. So it'll be 9:15 local, 8:15 for you when we start up.
Sounds good.
Thanks.
Eu quero usar seu corpinho, sua inteligência. A doutora vai fazer uma obstáculo 6 e ela precisa fazer uma projeção. Fazer um para na hora dos carros. Aí eu vou pedir projeção.
Hello. Hey. Good morning. I'm with Adrian. Come.
Where are we now?
Let's come to arrange and
Okay. We can just start from Tom in this case. It's actually very interesting. Pass it.
Só me confirma mesmo.
Eu vou olhar agora nas redes. Essas apresentações estão aqui.
Já estamos no 46, então faltam só 10, é isso?
Não.
Hã?
Deixa eu ver.
Ó, tá marcando 46 aqui.
Ah, sim.
Só faltam 10, né? Não falou que são
São
56.
56.
Vamos lá, então a gente vai terminar esse horário. If you want to put it here,
Very good, very good.
you're firm. Yep.
Hey, Tom.
Hey, we'll,
I have sent you the presentation and the Excel files through WeTransfer, so
got
they're
it.
available locally to leave with the community if you wish.
Okay, I appreciate that.
Can I ask, when do you plan to end, or Elliot, when do you plan to end?
10 in 45 minutes.
Elliot,
Yes,
to end at about 10 or what's it, 9 your time?
yes,
Yeah, because we got actually another thing starting here at 10.
yep, absolutely.
Here's the three
Yep.
presentations.
So go ahead and start, Elliot. They're walking in, but go ahead.
So, if you want to keep this
Thank
with
you.
you, okay?
Well, I was actually going to take a moment to ask questions of folks. So,
Yeah. Let me get them in. We're starting. There's some though you can start to ask.
okay. So, I wanted to get some feedback from you folks about what you're seeing in your own situations in the countries that you are working in these converging environments, and also in the diffusion of healthcare out of the hospital into self-empowered or community or home care settings. Does this situation resonate? Is this consistent with what you're observing? Or is this from another galaxy?
Thank you. Elliot, can I start?
Yes, please.
Okay, good. I think you already started perhaps a decade ago or more than 15 years ago, and in many countries, and I'm speaking on South Africa, we're still trying to find our way. So we don't have a specific direction per se. We see, this is an opportunity, but we are still very skeptical and scared in moving into that direction.
Okay.
There are some pockets in the private sector that are starting with a limited scope. But yeah, it makes sense, and it's an opportunity that sooner or later we have to deal with. Lucky you that you already started some time ago, so you are building, some experience and improvement and so on.
Okay.
My second input is you raised the issue of the IEEE standards for Wi-Fi communication, and you've been, or there was a suggestion that we should look at a health-based Wi-Fi standard, which might be a good way to address some of the security issues that applies to our environment, but they are not at the same sensitivity in other industries. So when we deal with patient information, patient files, communications with essential equipment in health facilities, it's not the same as other industrial applications. And I think it makes sense for us to explore it further and perhaps have more research work on that and have an area that belongs to us. And I feel strong about it because it will help us to address some of our safety concerns, which put many countries back and they don't want to touch this hot plate. The third issue I would like also to get your input in is we hear a lot about Internet of Things, and an idea came to my mind some time ago is why don't we look for something specific for us, and it's the medical Internet, where we can integrate medical devices or perhaps medical equipment, the big ones, into the healthcare system, into the electronic medical records, into the analysis of patient information or scans, and at the same time look at the performance of our technology and how we can, be proactive in terms of avoiding certain malfunctions, faults, and so on in the technology. So,
Okay.
medical Internet of Things, we can integrate everything in our healthcare environment, including the, what we call the big or the strategic medical equipment that healthcare services is, dependent on that.
Okay. So let me talk to a couple of those issues. Regarding the Wi-Fi, I spoke at one of the IEEE 802, what they call plenary meetings. They have 2 plenary meetings a year where they all gather. It's a very big group. It's about 1,000 people because Wi-Fi is a global technology, WiMAX, Zigbee, Bluetooth. And when I explained that what we are interested in healthcare are technologies that are reliable enough for life-critical applications and that are stable enough that we don't have to replace them every 2 or 3 years, that we want them to last for 5 or 10 years, and that we also want them to be separate from the other commercial systems so they are not contaminated or run the risk of cyber attacks that are being put on other generic systems. I was almost executed by the community who said, well, why would we do anything in that space? That financial model is insane. Why would we take life-critical risk, first of all? Why would we take a product? We like turnover of product every year or 2 years. You want us to have a product that's stable for 10? And then it got worse as we got into this. It was kind of enlightening for me to hear their perspective. That doesn't mean we shouldn't do it. We at AAMI, we have a group that has been talking for almost 10 years about what we are calling quote unquote medical grade wireless. The example I used way back when was, there are medical grade electrical outlets that were designed specifically to improve the safety for patients. And I think we may have to go down that path, but the manufacturers right now and the industry in general and the standards industry, extremely resistant. Basically, it's a no sale. Now, that doesn't mean that someone won't innovate and come up with, it seems to me, that if you have a software tunable a software tunable modem, that you could tune it to a sideband, you could tune it to a frequency that is just a little bit off without changing manufacturing specs very much at all, or only changing firmware, and then have a medical information and a medical focused technology. But I'll tell you, it was not a pretty picture when I presented that. To the other question that you asked about having devices integrate and provide data directly, we have and are doing that. Integrating the healthcare enterprise has had a patient care device program and project since 2005. I talked and have worked extensively with Kaiser Permanente and Tom Judd, Geisinger, and many government agencies on the implementation of that. And there are several standards bodies, including UL and AAMI, who are working on closed loop medical device interoperability and interfaces and standards for that. So I think that is coming. But with that comes a whole bunch of legislative, regulatory, and liability issues that are still, being discussed. And there is if you're interested in that, UL has a 2800 and a 2900 working group that is working on real-time, life-critical medical device interfaces. And I think that it's logical to me, and it's been logical to those of us working in this field, that we should automate the data capture as much as possible. And we do have, it's becoming less and less a technology issue and more of a cultural issue. Physicians and hospitals are now realizing, and nurses, that they're not all that trusting of that kind of automation. So I've had nurses and physicians say, I don't want that data put in my record. I want to be able to read every record and sign it off.
One more question. I know
Yep.
you need to get back.
Elliot, this is Elliot from Lebanon. Only two questions, two quick questions. First is, the more we automate, the more we have more information in the hands of the doctors and nurses. The more time they spend on these devices instead of spending time with the patient. It's only perception and something that we find on the ground. Maybe it differs from one place to the other, but we see that only automate things and we give them more information, the less they spend with the patients. And the second question about the total cost of pollution, does it cover the expenses, the operational cost after commissioning or just before commissioning?
The audio was sort of fading in and out. So Tom, could you just repeat those for me so I can respond?
And my brain was going in and out also, but I think what he was saying, the more we automate these systems around patient care, it has the possibility of drawing the clinicians away from patient care and running that risk. All the CEIT. Right. Does it enable better care or pull them away?
So let me talk about that for a moment. Well, there's several layers of this. There are researchers who are working more and more on the technology-human interface and having the technology actually be more friendly for the users and patients. There are some excellent groups in Japan and in the U.S. that are working on adding actually emotion and adding, I'm trying to think of the right terms. The difference is high tech and high touch. So only having high tech is not sufficient to provide the care and compassion and support patients need. So we have that problem. We also have the challenge of the physician and nurse being diverted to the technology instead of looking at the patient. And we're, to the extent possible, one of the areas that we have tried to focus on in the engineering is to automate the data capture so that nurse and physician can stay with the patient. The device can measure heart rate. The device cannot measure the look of fear or pain in the patient's eye or body. That's not something the device currently has any likelihood of being able to do. So the empathy, the awareness, the care, the compassion that a caregiver provides is maybe 9/10 of the care, not the pill. The fact that someone actually cared and listened and interacted. So we have to take the attention back. I mean, it's kind of like the unintended consequence of cell phones and texting. Who ever imagined people would text when they're driving at 80 miles an hour? But they do. And so they've taken their attention away from life-critical driving the car, people walking, pedestrians, other vehicles, to do something that technology has diverted them to. So this is a serious issue, a serious challenge that we have to overcome. But, you know, in cockpits and airplanes, in warfighting, we have been able to overcome many of those issues. But we are suffering from some of those challenges today. We also suffer from some very significant usability issues. Many of the systems that we use for technology today are lashed together, multi-vendor, multi-generational systems that do not interface or work well together. And while we have those systems functioning, the physicians and nurses are spending an inordinate amount of time logging in, logging out, translating, mapping, looking through menus. All of that has got to go away. That's got to all be put into the background. Just as with cars, things that have been automated, we get used to using, and they go to the background. That has to happen. What was the second question, Tom?
I think were all this total cost of ownership loaded at the front end, or are they really over the like? Is that mostly right idea?
Okay, so the answer is both. So some things. So let's just actually move back into the presentation, and we'll start talking about those total costs of ownership a bit more. And I should acknowledge that Binsang has done probably as much of this work or more than I have, and I have benefited greatly from his work in this area as well. The total cost of ownership, some of the costs you can anticipate, but not all of them. And to the extent you can anticipate, you really have an obligation professionally to do so. In today's world, to overlook the fact that batteries have to be changed, that software updates have to be accounted for, that bandwidth, that users expect very high bandwidth and expect real-time information and systems, those are naive mistakes that are our mistakes if we don't include those in our planning. What we cannot plan is the potential for very unexpected new innovations that disrupt. So think about 10 years ago was when the iPhone arrived. 8 years ago was when the iPad arrived. Android maybe about 6 years ago. These innovations took the market by storm and changed fundamentally the way people interact with technology. The uptake was enormous, and that has, you can't plan that. You don't know what the next big thing, or you don't know when Microsoft or Apple or Google may replace a technology with something they have behind the curtain that blindsides you. But to the extent that you can look at things like apps, to the extent to which you can look at your country's financial ability to support the population health that it needs by keeping centralized control and hospital-based control, or diffusion of care and use of more home technologies, you can anticipate some of that, and you can anticipate a good portion of what the liabilities are that come with that. The occasional blindside also of a recall of a 750,000 devices being recalled, you can't anticipate that either. Binsang and I had the uncomfortable pleasure of being in the midst of several major medical device recalls when a large portion of our fleet of devices either couldn't be rented or used, or the portion of our fleet that could be rented or used was completely depleted because there were no other products that could be used in the market. You can't anticipate all of those things. So our job, I think, as clinical engineers, as health technology managers, is to remove as much variability and unplanned problems as we possibly can. That also the risks, the other issues as we move into financial and financial modeling, we can't predict massive inflation or stagflation or devaluation of currencies. We can, and that's another reason why we look at these models as 5-year models, not 10-year models. 10-year models is guesstimates at best. 5 years is almost a guesstimate. Can you guess what the smartphone capacity or capabilities will be in 5 years? Can you guess what broadband or diffusion of home care will be in your country in 5 years? Can you guess what diseases will dominate. You can probably guess what diseases will dominate, but not if there is a massive change in the biopharmaceuticals or genetics genomics research. So we have an obligation to do the part that we can in advance. When I visited Binsang in Campinas, I think it was 1985, he was wrestling with a large number of, I believe they were Siemens monitors and patient care equipment that had been in warehouses for a long period of time, and he was trying to commission them into the hospitals, and there were problems with mold and fungus and deterioration of the equipment that made them almost useless and had enormous costs to recommission them. Those are the kinds of things you need to try to avoid. Even things like laptop computers, understanding that laptop computers have a finite life. If you have a laptop computer that lasts 3 years, you're lucky. If you have a laptop computer that lasts 5 years, it's a miracle. So you have to have replacement costs factored in if you're going to use these mobile technologies. How many of you have used the same smartphone for more than 3 or 4 years? In my experience, most people are replacing their smartphones every couple of years, or 3 years, or 4 years. I'm a Luddite, relatively. I'm still using an iPhone 4S because I can buy them for next to nothing, and they still function. But very few people do that. Most people use newer technologies and don't go back and retrace those old paths. So it's a long answer to your question, but I think we are entering an era in clinical engineering and health technology management where we really have to be looking at all of the probable costs we know are coming at us and include them in our models, and then use tools like the time value of money and net present value to get relatively honest comparisons of different alternatives. So I'm actually going to shift to a couple of spreadsheets in a moment to show you some examples of that. But the concept of net present value, it's fascinating. I taught for 10 years in a business school, and you would think that business students would understand net present value. And I found that 8 or 9 out of 10 had no clue and couldn't use the simplest spreadsheets to analyze net present value. I would have students do a term paper or project and ask them to do this kind of simple analysis for a car. What does it cost to buy a car and own it over 5 years? You can anticipate the capital cost, you can anticipate the depreciation, you can anticipate the cost of tires, gasoline, oil, tune-ups. You can add all those up, and having them then factor back in the reality that $1 today has real $1 value, but a cost 5 years from now has a lower value. You're making a commitment 5 years from now to buy something with tomorrow's money, and you could put that dollar in a bank and save it. Even those business students couldn't understand that concept, which is fairly simple and fairly startling. I mean, perhaps an indictment of business students that they can't do the basic math with a basic spreadsheet to figure that out. Now, in the U.S., we're in a period of extraordinarily low inflation and extraordinarily low interest rates. Much of the world isn't experiencing that, but we are experiencing a remarkable period. So when you talk to people about the cost of money or interest, they go, well, it's nothing. We don't have to worry about that. Or devaluation or depreciation, we don't have to worry about that. But it's a very artificial time. In reality, the cost of money is 5, 8, 10, 15, 20%. In some countries, 30%. Devaluations, all of those have to be factored in as you look at buying material supplies, spare parts, accessories from other nations with your dollars. The U.S. is living in a bubble that is not the same bubble that most of the rest of the world has been living in. So the whole concept of net present value is very simple. If I have $1 today, I could save it. Just using simple math, if it had a 10% interest, at the end of a year, it'd be worth $1.10. At the end of a year after that, it'd be $1.21. Another 10%, $1.32. We would add to that every year 10%, and at the end of 5 years, it might be worth $1.60. If we could save that. If we had to borrow that at 20%, we would be paying interest. So that dollar expense would accumulate interest at 20%. We would owe 20 cents in the first year, another 20 cents the next year, another 20 cents the next year, and that's even if we're not paying off the principal. If you can defer a cost, let's say you can look at a laptop computer and get a contract built into that computer where it will be replaced at the end of 5 years and you have no maintenance costs, then perhaps you're home free, perhaps. But if in fact the product it becomes unreliable at the end of 2.5 years, you can't really put off that cost. Well, it's under maintenance. We can't keep sending that laptop back and not providing medical care because that laptop isn't available to do the blood analysis or the ophthalmologic study or the prescription planning that it was intended to be used for. So we can build models very simply with spreadsheets that allow us to accumulate these costs and then look at over a 5-year period what these costs are. I'm not going to spend a lot of time on these spreadsheets. I have given a collection of these spreadsheets that Tom Judd has copies of. Glad to share with you, and you can contact me. I'd be glad to send them with you. I'm glad to work with you on your own models as you're trying to do this work. So let me change the display to one of the spreadsheets. And these models are not set in stone. They can be modified to meet your actual country or hospital or state model or requirements. I've put together some basic essentials. I think Binsang has helped expand these as well over the years, looking at things like inflation factors for labor. Inflation factors in the U.S. have been almost zero, but in other countries have been very high. Material, local material versus imported material varies. So you've got to factor in local material and imported materials, imported supplies and parts, repair parts, test equipment, currency devaluation. In each of these cases, you're taking a percentage and saying, let's say local materials, let's say in the U.S., material inflation has been artificially low at 2%. Then at the end of a year, your cost for materials for $1 materials is only $1.02. The second year, $1.04. Third year, $1.06. So if you're buying local materials like, let's say, batteries, A cells, AA cells, D cells, in the U.S. we have an extremely low inflation rate, artificially managed by the way we've handled our Fed. But in other countries, the local material costs have been going up very substantially. So in another country, that rate might be 12%. By changing the percentages to match a reasonable model of what you project in your country or in your state or in your hospital, you can begin to factor in real estimates of what the 5-year costs of things are, because you're able to build in either the value of a local dollar or the net present value. So the net present value is the inverse of the savings. So if I took $1 at 1%, it'd be worth $1.01, $1.02, $1.03, $1.04, $1.05. The other way of saying that is at the end of 5 years, if I was to have a dollar expense, if I saved $1 today, It's really, I only need to save 95 cents today. The net present value of a dollar committed 5 years from now is only 95 cents at a 1% rate. At a 12% rate, the number is dramatically different. A 5-year out expense is 56%. Or my real cost, if I make a commitment today to buy something at $1 a year with a 12% interest, supplies, $1,000, $10,000. That cost at the end of year 5 is going to be 1.76, $1.76, almost twice what the cost currently is. So a manufacturer who gives you a deal, who says, well, we're going to provide you with infusion cassettes or saline solution or bags or medicines at $1, and we're not going to change it other than increases in currency or devaluation, those costs over 5 years can mount up very steeply. They know that. They build that into their models plus their profits. So you can look at any particular acquisition and multiply out the costs and impacts of net present value. You can look at a capital purchase, for example, and look at things like the initial capital cost, $100,000 of, let's say, laptop computers. $100,000 of laptop computers, well, they're going to have, in terms of repair parts, you're going to have every 2 years at least, you're going to have batteries replaced. Let's say $100,000, let's say that's how many batteries are we going to replace in a laptop computer? Let's call these capital costs for laptops. $100 computers, we're going to replace 100 batteries, probably every 2 years. At $50 a battery. Not in this, every other year. What you do in this model is you lay out the cost for your 1, 2, 3, 4, and 5 based on what you actually expect those costs to be, those that you can anticipate. Batteries, keyboards, replacement units, software upgrades, all of those get laid out in this model. And if you have to increase a cost, for example, for local materials, let's say it's imported materials, you want to take $5,000 times a imported items inflation factor. In year 4, you're going to multiply it by G20. The actual cost at that time will be $6,000. By mapping each cost to its correct inflation factor, you can then find out the cost of all of the individual aspects of owning that technology. If you are talking about wireless communication, you may anticipate you actually have to double your number of access points. So you would factor in a complete doubling of your access points in order to support the bandwidth that you need to meet that. At the end of every one of these columns, when you get down to the total costs, you then have to go and do a computation for the net present value. You can also add in local items. Let's say you have local labor. You have to hire people to put up the new access points, hire people to install the batteries. Yep, I see it. I looked at it here myself. Thanks. Each of these you work down to total costs, and you can inflate or deflate according to the factors for your economy, for your marketplace. And then you total those columns and then reduce them back to net present values. What you really want to look at is the real cost today. What have you committed your organization to in the purchase of those products? So $100,000 capital equipment in the previous model is really a net present value commitment of $250,000 of expense. Now, you may still do it, you may still have the budget to do it, but if you don't have the budget to buy the spare parts, then you will be in the position that Bin Sang found himself in, and many countries find themselves in, where they have medical equipment or infrastructure that is not working. Now, Bin Sang and the rest of us have tried to come up with what percentage of equipment and biomedical technologies are not functional because of lack of support funding. Parts, staff, test equipment, repairs. We've heard numbers in the 50% area. Does anyone have a number that is realistic from your perspective about what percentage of health technologies that have been purchased and are used in your hospitals, states, or countries that are not working because of want of funds for repair, maintenance, technicians, parts, etc.?
No.
Nobody wants to rush and offer a number?
I'll figure it out.
Let's make it like a bidding war. I assume none of you have 100% of your equipment not working. How many of you would say 15% to 20% is not working for want of funds to provide repair and maintenance? Okay, 15%. How many of you would be closer to 30%? Okay. In your information technologies, laptops, computers, how many of your information technologies would you say are suffering for want of updates, replacement, batteries, power supplies? How many of them are inoperable? In the 15% area, how many would say in the 15% area? How many in the 20% area? Okay. Anyone up at like 40%? Okay. So you're getting supplies, you're getting repair parts, you're getting service, and I'm going to guess that it is a battle every year because you don't have, you're blindsided by costs that you didn't know or anticipate. And I'm saying I'm going to guess because I've been through that. Bin Sang and I were through that, managing the fleet of 500,000 medical devices for Medic. The hospitals that I have visited, the numbers that we have seen in the Infratech listserv has been as much as 50% of devices not being functional in some countries. I know when I visited Bin Sang in Campinas, when those devices were being commissioned, I think he was struggling with the 40 and 50% level, but he can speak for himself. The point of the modeling, the total cost of ownership, the point of the net present value analysis is to allow us to anticipate and remind us to anticipate the need for parts, for labor, for training, for infrastructure. And as we move into more CEIT integrated systems, we need to be more effective in understanding what our actual costs will be for wireless and wired networks, security and cybersecurity, backups, contingency plans, disaster planning and recovery. We have to have those numbers. We have to begin to develop those numbers and build them into our budgets. Because if we don't have them in our budgets, to expect the IT department to fund those is naive. And to base the patient care and patient safety on the IT department's ability to do that analysis is not likely to be successful. It isn't successful in the US. It is not likely to be successful in any other country. By and large, in many shops, The way they handle customer calls, questions, and service is with a help desk. And in the help desk, satisfaction rates are often in the 30 and 40%. Only the top echelon of the organization gets service and support, and everybody else waits in line for some limited support and service. You can't do that with a baby. You can't do that with a patient in intensive care. You can't tell them, hold that breath, we'll give you a call next week when we get the upgrade. So in these emerging, interconnected, interoperable systems, we've got to do better planning, better financial modeling. I have, again, these models and spreadsheets I've given to Tom to allow a sharing with all of you. And I'll be glad to work with you individually as you want to work on these models for your own applications in your own hospital, health systems, and paradigms. Just give me a moment. We'll come back and finish this up because I know we're running out of time.
By the way, Elliot, amazing.
So the truth about, I'm sorry, this is one of the anomalies of Zoom is it doesn't always tell you you aren't projecting what you think you are. So the truth about the proverbial iceberg of costs, everything is relative. Joel Noble, my mentor at ECRI, used to tell me a very annoying truth. He would say that truth is a perishable commodity. As a young person, I wanted to find real truth in the best devices, the best technologies. And the fact is, truth is a perishable technology because the facts change. In our healthcare field, clinical technologies are now kind of at the bottom of this iceberg. They're a small part of the actual clinical health technology management heap. We have bring your own device, PCs, upgrades, consulting, security, backups, cooling, telecommunications, quality of service issues, device integration issues, verification and validation, and tons of new costs that are arriving in the form of mHealth, patient portals, Internet of Things, telehealth, new apps and software, and regulations that are coming with that. The reality is that this is pushing the iceberg down. We're only seeing, I think, 5 to 10% of the purchase cost now, and our actual cost and obligation in managing health technology is being buried more deeply, but it's going to come back and is coming back to bite us in a large way. Any organization that has a significant IT and ICT and electronic medical record infrastructure is probably paying, I'm going to guess, 10 times what they're paying for health technology, pure health technology services, they're paying for the information technology support and backbone. And that is going to continue to be a dominant cost and effect in this field. I have a lot of examples here. You'll have these in the spreadsheets, so you'll be able to, you'll also have the presentation. I just want to point out that even in China, everywhere I go, the countries, the researchers are looking at integrating these information heaps and silos into better integrated information leverage tools. So this was from last year's, or from the first Clinical Engineering Congress. And this is an example from a hospital in Beijing and the integration of their information and advanced decision support systems. We're seeing that at national, local, regional levels all around the world. I think we really have to touch base with the health IT field. HIMSS has now HIMSS Latin America, HIMSS Asia, HIMSS Pacific, Europe. We have to work with these folks. They have an awful lot of funds invested. Basically, our clinical engineering societies are leading the way in innovation and sensitizing the field. We have to take a fairly aggressive position, which is lead me, follow me, or get out of my way. I'll leave you with this image, this reality that all of these integrated systems have vulnerabilities with natural and human-made disasters. This is not going to get less, this is going to get more. There's the yin and the yang of technology evolution. The good news is we have the ability to do more mobile, patient-centric precision medicine. And the bad news is we have to support a more complex infrastructure in order to actually make that happen reliably, safely, and affordably. Let's open the floor for a couple of questions. I know we're out of time, and then we'll turn the room over.
I'm afraid we don't have time for questions, my friend.
Well, you know how to reach me, folks. If I can help in any way, if I can share any information, I'm more than happy to. We're working on this program and these issues together. Have a great conference. I'm sorry I couldn't be there with you. Look forward to seeing you all at future meetings.
Thank you.
Dr. Iadunza.
Okay, good morning. We are right on time. We have 3 presentations today. The last days of the conference, I would say, and yes, 3 presentations.